Yellow means feel better, green means no difference, red means stroke, cross means dead. Figure 1.9, visual portrayal of benefits and risk. The image refers to an operation that is expected to relieve symptoms in 90% of patients but cause stroke in 2% and death in 1%. The SBAR system of communicating. SBAR example, a telephone call to the intensive care team. As for situation, I am dash calling from the place about a patient with a news score of 10 out of 10. Before background, patient's name, a 30-year-old woman, no past medical history, was admitted last night with community acquired pneumonia. Since then, her oxygen requirements have been steadily increasing. A for assessment. Her vital signs are blood pressure 115 by 60 millimeter mercury, heart rate 120 beats per minute, temperature 38 degrees Celsius, respiratory rate 32 beats per minute, oxygen saturations 89% on 15 liter via reservoir back mask, and arterial blood gas shows hydrogen ion 50 nanomole per liter, pH 7.3, partial pressure of carbon dioxide 4 kilopascal or 30 millimeter per mercury or 30 millimeter mercury, partial pressure of oxygen 7 kilopascal or 52.5 millimeter mercury, standard bicarbonate 14 millimole per liter. Chest X-ray shows extensive right lower zone consolidation. Recommend R for recommendation. Please, can you come and see her as soon as possible? I think she needs admission to intensive care. News National Hourly Warning Score. A patient with normal vital signs scores 0. See Royal College of Physicians National Hourly Warning Score News 2. Standardizing the assessment of acute illness severity in the NHS. Updated report on working party London RCP December 2017. Problem representation slash list and differential diagnosis. Once all the available data from history, physical examination, and sometimes initial test results are available, these need to be synthesized into a problem representation or a problem list. The process of generating a problem list ensures nothing is missed. The process of generating a differential diagnosis works against anchoring on a particular diagnosis too early, thereby avoiding search satisficing and premature closure. See figure 1.6. Mnemonic and checklist. These are used frequently in medicine in order to reduce reliance on fallible human memory. A, B, C, D, E. A for airway, B for breathing, C for circulation, D for disability, and E for exposure or examination is probably the most successful checklist in medicine used during the assessment and treatment of critically ill patients. A, B, C, D, E sometimes prefixed with C for control of any obvious problem. See page 191. Checklist ensure that important issues have been considered and completed, especially under conditions of complexity, stress, or fatigue. Red flags and rows rule out worst case scenario. These are strategies that force doctors to consider serious diseases that can present with common symptoms. Red flags in back pain are listed in box 26.19. Considering and investigating for possible pulmonary embolism in patients who present with pleuritic chest pain and breathlessness is a common example of ruling out a worst case scenario, as pulmonary embolism can be fatal if missed. Red flags and rows help to avoid cognitive biases such as the framing effect and premature closure. Newer studies to avoid cognitive biases and errors in decision making are emerging. This involve explicit training in clinical reasoning and human factors. In theory, if doctors are aware of this of the science of human thinking and decision making, then they are more able to think about their thinking, understand situations in which their decision making may be affected, and take steps to mitigate this. Clinical decision making, putting it all together. The following is a practical example that brings together many of the concepts outlined in this chapter. A 25-year-old woman presents with right-sided pleuritic chest pain and breathlessness. She reports that she had an upper respiratory tract infection a week ago and almost back to normal when the symptoms started. The patient has no past medical history and no family history, and her only medication is the combined oral contraceptive pill. On examination, her vital signs are normal: respiratory rate 19 beats per minute, oxygen saturations 98% on air, blood pressure 115 by 60 millimeter mercury, heart rate 90 beats per minute, temperature 37.5 degrees Celsius, and physical examination is also normal. You have been asked to assess her for the possibility of a pulmonary embolism. More information on pulmonary embolism can be found in chapter 17. Evidence based history and examination. Information from the history and physical examination is vital in deciding whether this could be a pulmonary embolism. Pleurisy and breathlessness are common presenting features of this disease but are also common presenting features in other diseases. There is nothing in the history to suggest an alternative diagnosis. Example: high fever, productive cough, recent chest trauma. The patient's vital signs are normal, as is the physical examination. However, very few individual findings help to distinguish patients with pulmonary embolism from those without it, the presence of which and high fever modestly decrease the probability of pulmonary embolism. The presence of hypoxemia is unhelpful. Likelihood ratio not significant. Deciding pretest probability. The prevalence of pulmonary embolism in 25-year-old women is low. We anchor on this prevalence and then adjust for individual patient factors. This patient has no major risk factors for pulmonary embolism. To assist our estimate of pretest probability, we could use a clinical